accuracy by looking at a simple photo, which we normally don't see any other information. So that to me was really eye-opening, because what we could potentially extract from very simple photographs of the optic nerve. And you know, when you look at an optic nerve, you know how challenging it is, especially if there is pericapillary atrophy and some other tilting and so forth. It's hard to tell, and we can learn a lot about that. But the question is, just like we cannot tell whether this is a male or female retina by looking at a fundus photo, what if we now apply this technology to looking at optic disc and other things we cannot tell from a simple photograph? And I think I just want to leave you with that thought, because we just got the first FDA-approved device for screening for diabetic retinopathy by IDX. Again, it has about an 88% efficacy. I don't think that's great, super great, but it's a great beginning. And I think we're going to see a lot of that. And really, next-gen diagnostics with artificial intelligence, basically we're going to take existing tools, which are as good as we've gotten them to be, like the fundus photo, like the RNFL. And the question is, what happens when we add AI to that? And it may turn out that if you take fundus and you add fundus plus AI, you can actually get more information than RNFL alone. Just like we know currently that you can, an AI system can predict if somebody is a male or female looking by a simple photo that we wouldn't understand from a fundus. But I would like to switch gears a little bit, because I think the diagnostic part is something we're going to see unfold. But what good is diagnostic? How great is it if you can diagnose somebody who has glaucoma, and you go through all that fancy way of diagnosing it and using AI or no FI or RNFL, and ultimately we cannot treat those patients. Half of them are not compliant, half of them are not. Well, actually, now we know that half of the patients cannot accurately dose. I mean, where else in medicine do we have that, where we cannot accurately dose? If we give somebody an antibiotic pill, and we know that half of the time it doesn't get in, or if you give somebody a vaccination, well, you know half of the time the vaccination doesn't happen. And we're dealing with legacy technology. So how can we make therapeutics smarter, more intelligent, more efficient, and ultimately more effective? Interestingly, the pipette paradigm has endured almost 100 years. Our legacy eyedropper, which we currently use, has been around for a long time. And although the form factor has changed from a pipette with a glass to a plastic, that's all it is. It's exactly the same. And here is a patient of mine who came in and she was headed for a trap, and her arthritis was getting worse and her pressure was elevating. And so we were going to do a trap until we realized that, let's see how she puts the eye drops in. And you can see carefully, half of the time, or 80% of the eye drops she couldn't put in. That's how I got into that. Was a patient at UCSF. Now what happens in the other half of the time when by chance the drop gets in? Watch that still video, and actually it's interesting because that's not exactly what happens, but it's very close. Most of it drips out. And your eye can only hold 7 to 8 microliters. An eye drop has about 40 or 50. So where does the excess go? So not only are we poor at putting drops 50% of the time in the eye, but even when we pour them in, we're actually putting them out. So no AI is needed to realize the eyedropper ain't smart, pardon my French, because it ain't. And it's a century-old pipette. It overdoses the eye by 300%. Because if you get in, and on average patients put 2 drops or 3 when they get in. So they miss it 50% of the time, and when they get it in, they overdose by 300%. I mean, it really makes no sense. But that's why we end up with a lot of things like hyperemia, red eye, discomfort, prostaglandins get periorbitopathy, sometimes eyes. Why do they get that? Because we're overdosing, and we're dosing in the wrong place. We're not dosing on the cornea, where 80% of bioavailability happens. We're dosing on the conjunctiva. It's just totally counterintuitive. So patients respond to our imperfect treatment by serving us back with poor compliance and side effects. So 100 years with only tiny incremental change going from a pipette paradigm to a pipette paradigm in a plastic bottle. So what's next? Can we actually do something better? Can we improve? And one of the technologies I've been working on more recently is the shrunk version of an inkjet printer. We've been able to shrink the inkjet printer to a palm-sized device that actually uses piezo shrink technology to deliver horizontal delivery of a microdose, exactly 7 microliters, to the front of the eye, and nowhere else but the cornea and the ocular surface of the cornea, because that's where 80% of the bioavailability happens. And it's also an electronic system which has compliance monitoring 100%. So when the patient clicks it, it goes through the smartphone to the cloud, and now we can do a lot of things with the data. Because suddenly we have data on compliance. We can match that with your other stuff, and we can understand what's happening to those patients and why they don't respond. Because improving somebody's effectiveness of treatment of somebody who's non-compliant by adding another drug and lowering their compliance even further is not a good way to go. So this is actually very, it turned out it was a bit of a harder project than I thought, because even though it was just a different form factor, it had dramatically different utility and value propositions and different delivery of innovation on different spectrums of the innovation spectrum here. First, we had to solve the problem of microdosing, which has been around for 100 years, and deliver exactly 6 to 7 physiologic dosing versus the 30. Second, we had to solve the problem of targeted delivery. We don't want to deliver it on the time. It had to be delivered fast. We had to beat the blink, and we beat the blink because we use the piezo print. It's about 80 milliseconds. And on top of that, we put that up into the compliance monitoring and medication tracking system. That now we can have smart therapeutics. And so we've completed now 3 phase 2 trials, and we've shown that a properly delivered, smartly delivered, precisely delivered microdose gives you pretty much the same effect, biological effect, with 90% reduction of toxic exposure to medication, overdose, preservative, and all that. And now we're doing 2 programs, phase 3, that we're going in mydriasis, in glaucoma, and myopic progression, because as you know, atropine microdose or low concentration is literally perfectly suited to that kind of. And more importantly, we're going to be smart. We're going to generate that data in our cloud so that we know when Ms. Smith didn't take medication, why hasn't she taken it? She can get reminders. Big format. I want to show you a little video of a kid that shows how they can use the technology. It's really straightforward. I mean, it takes 1 minute to learn it. And so for me, what we currently do is that. And part of this is a little sketch here. That's what a drop does, a little beetle or cockroach. Here's what kids with microdrops do with a high precision delivery. So this is the technology, and it's being developed for a company called Ianchulev. Again, thank you very much for your attention. You're very welcome.